Hello, our champions. Lovely greetings from Dr. Rami Cardio Club. Today, I would like to take you in another destination in our journey pharmacology case. So let's start with a lovely case. Your patient is 50 years old man with well-controlled type 2 diabetes and normal renal function, and there is no microalbuminuria. So which of the following drugs would be the most rational first choice for starting his antihypertensive therapy? Do you think antihypertensive should be angiotensin converting enzyme inhibitor, beta adrenergic blocker, nifedipine, which is a calcium channel blocker, thiazide diuretic, verapamil, or diltiazem, which are another calcium channel blockers? So which one you choose? Yes, exactly, angiotensin converting enzyme inhibitor. Whenever you start an antihypertensive for your patient, you should start with A. A comes first, unless it is contraindicated. So angiotensin converting enzyme inhibitor, ACE inhibitor, is the best choice in this scenario. If you would like to remember antihypertensives and study them in a smart way, plan yourself with A, B, C, D, and miscellaneous group. ACE inhibitors like lisinopril, ramipril, perindopril, ARBS, angiotensin receptor blockers like candesartan, telmisartan, irbesartan, alpha-1 blockers like doxazosine, tirazosin, prazosin, alpha-2 agonists like clonidine, which are inhibiting the release of sympathomimetic agents like epinephrine and norepinephrine centrally, alpha-methyl dopa, which is the best choice for a pregnant female, and aliskiren, which is a renin inhibitor, renin antagonist, aliskiren. The other group is beta blockers, which are divided into non-selective group like propranolol, beta 1 selective group like bisoprolol, nebivolol, metoprolol, or a selective beta 1 with alpha blocking effect like lapitalol and carvedilol. Calcium channel blockers are divided into dihydropyridine like amlodipine, nifedipine, or non-dihydropyridine, which are working more on the cardiac rhythm and the contractile function of the heart like verapamil and diltiazem. Diuretics, which are divided into thiazide diuretics, loop diuretics, and potassium sparing diuretics. Miscellaneous group hydralazine, sodium nitroprusside, which are used for hypertensive emergency or urgency, and magnesium sulfate, which is reserved for the preeclampsia and eclampsia pregnant ladies. Right? So let's talk shortly about ACE or ARBS, what we know and what we don't know. ACE or ARBS are best to use as initial therapy for hypertension unless they are contraindicated, as I will show for you. Cornerstone is the treatment of hypertension, especially if your patient has ischemic heart disease or cardiomyopathy, and they are used for ischemic heart disease and cardiomyopathy in absence of hypertension because they improve morbidity and mortality. Should be used once microalbuminuria is evident. And what is more interesting is, if your patient is normotensive and he has diabetes and they develop the microalbuminuria, you should use ACE or ARBS to decrease the microalbuminuria, because as we all know, the regulation of the renal blood flow through the afferent and the afferent arterioles. The afferent arteriole is responding to prostaglandins, so it is affected by non-steroidals, but the efferent arteriole is regulated by the angiotensin system. So when you use ACE inhibitor or ARBS, you are causing efferent arterial vasodilatation, and here the glomerular pressure will be dropped and the albumin filtration in the Bowman capsule will be decreased. That's why you are decreasing the glomerular pressure. Okay. Careful use in patients with chronic kidney disease because they may cause hyperkalemia. They are beneficial in reducing left ventricular hypertrophy, decreasing the incidence of arrhythmias and the cardiovascular morbidities and mortalities. ACE inhibitors causes dry cough because angiotensin converting enzyme is present in the lungs and they are essential for degradation of bradykinin, which are causing irritation in the bronchial tree, causing dry cough. So ACE inhibitor will be causing accumulation of bradykinins. That's why they cause dry cough, and whenever it happens, we should shift to ARBS group. They are not preferred in hypertrophic obstructive cardiomyopathy because they are arterial vasodilators. So if your patient has HOOCAM, hypertrophic obstructive cardiomyopathy, the pressure gradient across the left ventricular outflow tract, LVOT, will be increased. Your patient may have syncope so easy. That's why they are contraindicated. This is the first contraindication for use of ACE or ARBS, ACE inhibitors or ARBS. They are also contraindicated in chronic kidney disease for fear of hyperkalemia, which is lethal because hyperkalemia may cause asystole and they are causing many arrhythmias. It's very dangerous. So they are not used if your creatinine level is above 3 mg per deciliters. They are also contraindicated in pregnancy. Why? Because they are linked to multiple congenital malformations. They are causing hypotension in the baby and kidney failure. We all know that the amniotic fluid is secreted by the baby. It is the baby urine. So if they have kidney failure, we will have oligohydramnios, which is very dangerous for the baby. Also, the lung hypoplasia may happen and bony defects. That's why we never use ACE or ARBS in pregnancy. My beloved doctors, I wish you the best of luck in your endeavor. I will be welcoming your questions and concerns. Just text us and we are responding to your comments. See you in another video. Bye bye.